you virtually. I'm sorry that I can't be in person in Virginia. I'm very much a child of Virginia, and as Ben-Cora mentioned, I grew up in the Midlothian area and also went to college at William and Mary, so my Virginia ties run very deep. And it is such a pleasure to be virtually with you all today. So we are going to talk about social justice and mental health. And the title said, bending the arc, and that comes from a quote from Martin Luther King, who said that the arc of the moral universe is long, but it bends towards justice. And so today we are going to spend some time defining some key concepts associated with social justice and mental health. We're going to evaluate the evidence base of the impact of social injustice on behavioral health outcomes, and we're going to try to identify some solutions to dismantle structural racism and achieve social justice in psychiatry. But before we get into all of that, I have to make a disclosure, or maybe it's a disclaimer, it's a little bit of both. I have to acknowledge that we are about to wade into some difficult and uncomfortable topics. And so as a result, as we talk about these things, often I've noticed that complex feelings emerge in people when we have these discussions. Some of those feelings might include things like guilt, anger, resentment, or defensiveness. You may perceive me of accusing you of being racist or sexist or homophobic or any number of other isms. And you also may feel that I have a specific political agenda or that I lack objectivity. I'm pointing out all of these things that I say you may feel because these have all been things that have been expressed to me whenever we've talked about this topic, and sometimes even when we're not talking about this topic. So I would just encourage all of us as people who work within the mental health field, that if you start to notice some of these feelings arising, if you start to feel some of these things, it's a really great time to spend some time thinking inward and doing a little bit of self-reflection as to why those feelings are emerging. And also it helps to think about the words of James Baldwin, who said, "I'm not interested in anyone's guilt. Guilt is a luxury that we can no longer afford. I know you didn't do it and I didn't do it either. But I am responsible for it because I am a man and a citizen of this country, and you are responsible for it for the very same reason." So with that, we can kind of get to the topic at hand. And so we are going to spend a little bit of time talking about race and racism and social injustice as it relates to mental health. And one of the reasons why it's so hard to talk about these topics is because we have been socialized to believe that it is not polite to talk about these types of issues. It's not polite to talk about race or racism or oppression. This starts early when we're very young, not only in the United States, but also in other countries, but it's particularly salient in the United States. And also health professionals have not been taught about the connection between oppression and health. And so educational systems have had a very long tradition of teaching a concept known as biological determinism, which I'm going to define a little bit later on in this talk. And the other reason why it's so difficult to talk about these topics is because in the wake of the death of George Floyd and countless other racial injustices that occurred last year, there was a sea change that occurred. And we saw a huge shift in the focus and the desire for people to try to directly combat racism. And definitely in that time, I think many people felt like, and maybe feel a little bit exhausted around the focus of racial injustice, and perhaps feel that there's been an overemphasis or an overcorrection that's happening right now when we talk about race. And all of those things make it very hard to talk about these issues of social injustice. Another reason why it's hard to talk about social justice in particular is because it's kind of a politicized and loaded term. And so this is an article that was published in the Wall Street Journal, an op-ed by Dr. Stanley Goldfarb, who was the Dean of Curriculum at the University of Pennsylvania School of Medicine. And his article is really quite interesting. He was basically lamenting about the idea that there is too much focus on social justice entering into medical school curricula as time goes on. And one of the things he said was, why have medical schools become a target for inculcating social policy when the stated purpose of medical education since Hippocrates has been to develop individuals who know how to cure patients? And then he also said, curricula will increasingly focus on climate change, social inequities, gun violence, bias, and other progressive causes only tangentially related to treating illness. And so will many of your doctors in coming years. And so he was not particularly pleased at the focus that was happening as it relates to social justice. And that is a perspective that I think is shared by a lot of different people within the field. Of course, he did have his detractors and people who disagreed with this concept. And so an article that was published by several of his colleagues in the Philadelphia Inquirer said that social and health policies have always determined who gets sick and who gets care and where and how. Understanding the social drivers of health and illness is not peripheral or tangential to health. It is the key to diagnosing and meeting a patient's fundamental needs. And I would submit to you that that is the work that we have to think about. We have to think about how these social drivers of health are the key to diagnosing and meeting our clients' fundamental needs. So yes, the concept of social justice is a bit controversial, and I think it's important that we define it. It is, in fact, a philosophical term. And so one of the philosophers that really focused on it, David Miller, said that social justice was the distribution of good or advantages and bad or disadvantages in society, and more specifically, how these things should be distributed in society. So he also said that social justice was concerned with the ways that resources are allocated to people by social institutions. And then adding on to that definition is another philosopher, John Rawls, who said that social justice is assuring the protection of equal access to liberties, rights, and opportunities, as well as taking care of the least advantaged members of society. So these are the ways that we think about social justice. And so we're really talking about how do we decide who in our society is worthy of certain advantages, who in our society is less worthy of such advantages, and also how do we take care of those who are least advantaged in our society. And so when we talk about who are the people that are least advantaged in our society, oftentimes that gets us to a couple of things. One, people with serious and persistent mental health problems, or people with substance use disorders. And it also gets us very quickly to the discussion of race again. And so it's important that we take a little bit of time to think about how race relates when we think about clinical care and when we think about taking care of clients, especially clients with mental health needs. So one of the things that is bandied about all the time is this idea that race is a social and political construct. We hear this over and over again. And I have to say that I used to hear the term that race is a social and a political construct for many years before I really understand what was being said or what was meant by that. And really, when we say that race is a social or political construct, we're saying that race was actually constructed, that it did not really exist in society, but was constructed by society and for the purpose of social advancing or political means or political desires and social desires. So as a result, when we say that race is a social and political construct, we are saying that race cannot be accurately genetically or biologically categorized. So what we do know is that you cannot draw somebody's blood and determine what race they are. You cannot run a genetic test and determine what somebody's race is. It is not able to be categorized in such a way. So what we know is that race is in fact a rough and imprecise proxy for culture, genetics, and socioeconomic status. And yet we use race to confirm a number of assumptions, prejudices, and biases about our patients. I think it's very interesting that we often talk about race in genetic terms, when in fact there is greater genetic diversity within racial groups than there is across racial groups. So we really have no basis by which we can say that we can categorize people into races based on genetics. So I'd like us to ponder for a second this particular quotation. It says, African Americans have higher incarceration rates, higher unemployment, lower incomes, lower home and business ownership, less education, less healthcare, more disease, and lower life expectancy than whites. If you believe Blacks are naturally dumb, sick, criminal, you have your answer for these discrepancies. If, however, you resist using stereotypes to make sense of your world, institutional racism provides a very practical and very traceable explanation for the inferior societal position of African Americans. The reason why I think it's so important to consider this quote is because when I think about medicine, and particularly when I think about mental health care, I do feel that even though we're all well-meaning people and we do our very best, that sometimes we default to this belief that maybe certain populations, and Blacks in particular, maybe they are naturally dumb or sick or criminal. And maybe that is the explanation for the discrepancies that we see, rather than the practical and traceable explanation that institutional racism provides. And I'll talk a little bit more about that. So it's important for us to understand how we got to where we are today. And that requires that we have a little bit of a history lesson. And so this painting may be familiar to some people. It is the signers of the Declaration of Independence. And we remember very clearly that that declaration had this famous line in it: we hold these truths to be self-evident, that all men are created equal, that they are endowed by their creator with certain unalienable rights, that among these are life, liberty, and the pursuit of happiness. So a beautiful ideal by which this country was founded and created. But what we do understand in looking at this painting is that of all of these of these rights that they were speaking of, that all men are created equal, we really do understand that when these signers were in this room getting ready to sign this declaration, they really weren't talking about all people. One, they were talking about men, and specifically they were talking about a very specific type of men. They were talking about the men that you see here in this room. And so for those people, they had in their mind that those people were endowed by their creator with certain unalienable rights, but that those rights did not extend to anybody that did not look like the signers that are in this room. And that's kind of the ideals by which this country was founded upon. And then maybe some 50 years later, a physician by the name of Dr. Samuel Cartwright started defining what he noticed as mental health problems in slaves and enslaved Africans. And so one of the things that he pointed out was a condition called drapetomania. And this condition was really the idea that a slave had a mental illness of wanting to escape captivity or wanting to run away from slavery. So he defined that as a mental health problem. And he said about drapetomania, if any one or more of them at any time are inclined to raise their heads to a level with their master or overseer, humanity in their own good requires that they should be punished until they fall into that submissive state which was intended for them to occupy. They have only to be kept in that state and treated like children to prevent and cure them from running away. And the other condition he described was a condition called dysesthesia ethiopica. And he said that this was a disease of rascality, or the disease of this natural tendency of enslaved Africans to be lazy, to not really want to work. And so he said this disease is the natural offspring of Negro liberty, the liberty to be idle, to wallow in filth, and to indulge in improper food and drinks. After the prescribed course of treatment, the slave will look grateful and thankful to the white man whose compulsory power has restored his sensation and dispelled the mist that clouded his intellect. So both of these conditions is really the origin of when we began to see that certain natural and normal behaviors were pathologized and seen as some type of mental health condition when they were normal reactions to regular behavior. Particularly as we think about dysesthesia ethiopica, this idea that a slave that was not working at the peak level of what Cartwright determined his or her potential to be is very interesting, given the fact that many slave owners significantly restricted rations and food to slaves in order to save money. And therefore, many enslaved Africans were extremely malnourished and yet still expected to produce an extensive amount of work and labor under conditions of malnourishment and extreme dehydration and malnourishment. So this idea that this liberty to be idle or to wallow in filth and to indulge in food, improper food and drinks, really did not have any of the context behind why certain behaviors were seen or witnessed. But what we do know is that in current day, there still is some association between the idea that Black people are maybe lazy or Black people don't want to work very hard. And we can see that maybe there are these origins that started even in this time. And then the other thing that we notice about these particular conditions that Cartwright defined is that he had a very specific idea of how these conditions should be treated. And so for both of these conditions, he felt that the treatment of that was most effective would be whipping. And so the idea that these types of harmful treatments, that treatment would be some type of punishment, also has had some persistence in the ways that we think about mental health conditions today. So now I'd like to take a minute to define and note the differences between health disparities and health inequities. So health disparities are differences in health status among distinct segments of the population, including differences that occur by gender, race or ethnicity, education or income, disability, or where you live. And I, again, want to contrast that with the definition of health inequities. So health inequities are disparities in health that are the result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. So the reason why it's so important to think about these two definitions and how they are different is that health disparities is really just saying that there is a difference in health, but it doesn't really describe or define the origin of that difference. It just says there's a difference. Whereas health inequities very specifically says that the difference that we see in health is the result of systemic, avoidable, and unjust social and economic policies and practices. And the reason that that's so important is if you do not state what the cause of the difference is, we have this tendency, we have this default way of being in which we often tend to think that perhaps that the cause of that difference has to do with that particular person or that particular population. And so we tend to seat the pathology within the individual or within that population. We tend to say, oh, that particular population has worse outcomes because they make different choices about what they value. They maybe don't eat the same foods. They don't care about the same things. And that is why we see these differences in health. And so we tend to say, we tend to default to thinking that the cause lies within that group, rather than thinking default about the systemic, avoidable, and unjust social and economic policies and practices that create these barriers. And one of the things that I hope that we will kind of identify as we go on is that almost every difference in health that we see, particularly differences as it relates to mental health and differences that relates to substance use disorders, they aren't differences that are the result of personal choices or population level cultural differences. They are differences that are due to systemic, avoidable, and unjust social and economic policies and practices. So that gets us to thinking about this concept of the social determinants of mental health. And this work has been kind of a journey for me, and this is where this work started, thinking about social determinants of mental health. So they are defined as the societal, environmental, and economic conditions that impact and affect mental health outcomes across various populations. These conditions are shaped by the distribution of money, power, and resources at global, national, and local levels, which are themselves influenced by policy choices. And the social determinants of health are prominently responsible for the health disparities, inequities that we see both within and among populations. So we just talked about how those systemic, unjust, and avoidable public policies lead to health inequities. And the social determinants of health are really just defining and describing that in greater detail, that the social determinants of health are the things that lead to those health disparities and inequities. So as I mentioned, I had really kind of stumbled onto this work first by thinking about the social determinants of health and specifically the social determinants of mental health. And so Michael Compton and I, in writing editing the social determinants of mental health book, really sought to take all of the available evidence about what were the social determinants and what were those outcomes and which outcomes did they lead to in terms of mental health and substance use disorders. And as I started thinking about those things, that naturally led me to starting to understand that social injustice really underlies the creation of the social determinants of mental health. And so most recently, Sarah Vincent and I set out to edit this volume, which really gets to the heart of that issue. And I'm going to explain and walk you through that right now. So at the top of this figure, you see adverse mental health outcomes and mental health inequities. And as you move down the figure, you're actually moving further upstream. So each level is one level further upstream. So right below the driving factor that leads to adverse mental health outcomes and mental health inequities are a number of risk factors. And we know that risk factors precede a condition and increase the likelihood of someone developing that condition. So a risk factor is something that in mental health and substance use work, we spend a lot of time trying to identify so that we can intervene and prevent someone from developing a mental illness or a mental health problem and prevent these inequities that we see. And so those risk factors include things like reduced options or poor choices, behavioral risk factors, physiologic stress responses, and psychological stress. And what we understand about those risk factors, again, is that we try to intervene and we spend a lot of time in mental health trying to intervene. But when thinking about the social determinants of mental health, if you're intervening at the level of the risk factor, you are often intervening too late because there is a number of things that have set the context for the creation of that risk factor. Those are the social determinants of health, or what Lincoln Phelan called the fundamental causes of disease, or what Jeffrey Rose and Michael Marmot call the causes of the causes. So those things that lead to and set the context for the development of the risk factor. Those social determinants of mental health are all of these things that you see listed in these 4 boxes in the center. So that includes things like adverse early life experiences and discrimination and exposure to violence and conflict and interaction with the criminal justice system, low education and unemployment and poverty, and homelessness and food insecurity and transportation insecurity and poor access to health care, and adverse features of the built environment and neighborhood disorder and pollution exposure and climate change. So all of those things are the social determinants of mental health. They lead to the creation of the risk factor, which then leads to the adverse mental health outcomes and the mental health inequities. But again, as I've been thinking about this work, I've come to understand that if you are intervening at the level of the social determinant, you're still intervening too late because there is still context that was set and created long before the development of the social determinant. And the context that created the social determinant is social injustice or unfair and unjust distribution of opportunity in our society. Then the thing driving the unfair and unjust distribution of opportunity in our society are 2 things: social norms, or our beliefs that we have about the intrinsic value of some people and the intrinsic lack of value of others. So our beliefs about who is worthy of advantages in our society and who is not, and public policies, the laws that we pass that reflect those values. And so if we think that a certain population is worthy of advantages, we pass laws that reflect those beliefs, and that creates unfair and unjust distribution of opportunity. And often if we think that a population is less worthy of advantage, those laws reflect those beliefs and again drive this unfair and unjust distribution of opportunity. So we can think about what are our social norms about people who have mental health problems or people who have substance use disorders, and then think about all of the many policies that we have created that reflect that belief system. For instance, the fact that we do not have true parity between the ways that we treat physical health conditions versus mental health conditions in this country has a lot to do with our social norms about what mental illness is, and the laws and policies that we've created around around creating the mental health system. So how we have structured the mental health system based on our beliefs about how worthy the people that need those services are. And so I'd like to give another example right now, and it requires us to do a little bit of thinking about what are our social norms around people who use crack cocaine. And so I would ask you to just spend a second reflecting on the image that comes to your mind, or the image that comes to most people's mind when they think about somebody who uses crack cocaine. And probably the image that you have in your mind is of a Black person, a poor Black person. And if they're a man, they are probably somebody who is dangerous and perhaps a criminal. And if they're a woman, you may have this idea that they're a crack mother or a dangerous woman who's risking her children's safety and putting her needs above her family and her children just to get more crack. These are the mental images that have been kind of crafted in our society by the media. It has not necessarily actually reflected the accuracy of who uses crack cocaine most commonly in this country, but it does have some weight due to the way that the media has portrayed who uses crack cocaine, and then also the moral hazard that has really risen as a result, particularly in the 80s, of the idea that crack cocaine was a problem that we needed to address. So we have these negative social norms around the types of people who use crack cocaine. And as a result, we passed certain laws and policies that reflect those beliefs. And one of them was in 1986, we passed the Anti-Drug Abuse Act. And the Anti-Drug Abuse Act created a 100-to-1 jail sentencing disparity between crack cocaine and powder cocaine. And so the idea was that if you had 1 gram of crack in your possession and you were arrested, you would get the exact same sentence as somebody who had 100 grams of powder cocaine. It so happens that our belief system is that Black people were more commonly using crack cocaine, or we had the idea that Black people were more commonly using crack cocaine and that white people were more commonly using powder cocaine. And so we created this disparity, even though these drugs are actually no different, their chemical compounds are the same. So the same drug that had widely different sentencing disparities based on who was more likely to use it, and then the criminalization of that use. So that 100-to-1 jail sentencing disparity decimated African-American communities. And what you saw was that that law then created unfair and unjust distribution of opportunity within society. And that led to a host of social determinants of mental health. That includes things like poverty, difficulty once you were released from prison with unemployment, difficulty getting access to health insurance because of poverty, problems with food insecurity, discrimination, again, employment discrimination that occurs upon being released from jail. So a number of social determinants, but also intergenerational social determinants of mental health, because one of the adverse childhood experiences that's on the list of the traditional 10 ACEs is having a parent that is incarcerated. So that is considered to be one of the core adverse childhood experiences. And so if you had a parent that was incarcerated, then that's now affecting and creating social determinants of mental health that are affecting whole families and having a ripple effect around communities. The other thing that's interesting about this jail sentencing disparity is that in 2010, there was a big push to change the policy, and the policy was changed to a sentencing disparity of 18-to-1. So the sentencing disparity still exists. And again, even though there is no credible scientific data to say that there should be any sort of sentencing disparity, it still is an 18-to-1 disparity. There is movement in Congress right now trying to eliminate this to move to a 1-to-1 disparity, but it has not gotten that much traction as of yet. And the other thing I think it's important to think about when we use crack cocaine as an example is this idea that when we think about crack cocaine and it being a substance use disorder, we tend to not focus on the treatment of crack cocaine use or crack use disorder or cocaine use disorder in the ways that we do other drugs. And this is pointed out by Ernest Drucker in his book, A Plague of Prisons, when he said the fundamental clinical accountability of drug treatment professionals to individual patients has been subordinated to the goals of the criminal justice system. The other thing that's interesting about that is that for mental health, for substance use treatment, much of our care is provided through NA and AA, which is often set in church settings. And there's no problem with church settings, but it does imply that there's some sort of moral or spiritual failing as opposed to a medical condition, which is what many people consider substance use disorders to be, and what we clearly have enough evidence to know that substance use disorders are. So I'd like us to contrast that with our social norms around people who use opioids and the opioid use epidemic. And the idea that we don't necessarily have the same image in our mind when we think about somebody who uses opioids. Our social norms are different. And as a result of the different social norms that we have different public policies around how we treat and how we manage opioid use disorders. First, we do not consider opioid use disorders to be associated with criminality in the same way. We don't arrest people or put people in jail with the same rate that we do for people who use crack cocaine. And also, we tend to believe that the people that have opioid use disorders are good, well-meaning people who are really trying to care for themselves and for others. We consider it to be a public health crisis, and our interventions are very much focused on medical treatments for substance use disorders. And again, much of that, and I recognize that I'm simplifying a very complicated topic, and so there is definitely some room for interpretation here. But in general, if we're trying to simplify a very complex thing, in general, we can say that our social norms and our values around the types of people who use opioids versus the types of people who use crack are very different. And they have resulted in very different policies and very different outcomes for the people who use those drugs. Okay, so moving on, I'd like to cover a couple of key concepts. So again, I mentioned at the start that we don't spend a lot of time thinking about oppression and how oppression leads to poor health outcomes, and particularly poor mental health outcomes. So I'd like to take a minute to talk about several different types of oppression. This is work by Iris Marion Young on the 5 faces of oppression. So the first is exploitation. This is the unequal exchange of one group's labor and energies for another group's advantage and advancement. So clearly, when we think about exploitation, what comes to mind is obviously slavery, but we have many examples of modern day exploitation, including treatment of migrant farm workers, human trafficking, whether that be sex trafficking or labor trafficking. So there's many, many examples of exploitation that are happening today. Cultural imperialism is establishing the ruling class culture as the norm and othering all those groups that are not part of the dominant culture. This is something that we are always at risk to doing in mental health because we often take the dominant culture to be what is correct, and then any other behavior that does not behave within the norms of that dominant culture are considered to be incorrect. So for much of the time, the dominant culture in our society in the United States is white men. And so we tend to look at the behavior of white men as kind of what is right and what is acceptable. And then anybody who behaves outside of that behavior is considered to have pathological behavior. But another example of cultural imperialism that I want to highlight has to do with research. And so oftentimes when we're doing research, we look at odds ratios or rate ratios, and we compare to see if there are differences in outcomes in we compare one population to a reference group. And we identify the reference group. We have no guidelines on how we identify the reference group. We just kind of pick a population to be the reference, and then we compare those populations to that reference. And one of the things I found very interesting over the years is that whenever we're looking at rate ratios or odds ratios as it relates to race, the reference group is always white. And many, many times, but not always, but many times when we are looking at odds ratios as it relates to gender, the reference group is men. And again, this is not something that we have spent a lot of time questioning or wondering about, but it is very interesting that we often default to what we consider to be the norm or the reference group. Powerlessness is when oppressed groups lack power or are blocked from routes to gaining power. And this is when you take away any group's voice or their ability to kind of advocate for themselves. And so within mental health, we actually see this in the ways that we have stripped power from people who have lived experience. And so they do not necessarily have the same power, the same rights to make decisions about how they receive their care or what their care looks like. But we also see powerlessness as it relates to voter suppression and not allowing people to represent themselves appropriately. So we see many examples throughout any government, be it local or state or federal governments, where the people that are representing a community do not reflect the demographics of that particular community. And that is an example of powerlessness. Marginalization is when we expel specific groups from meaningful participation in society. Clearly, one of the best examples of this is the treatment of indigenous populations at the founding of this country. But we also have seen examples of this throughout history, including Japanese internment, the Chinese Exclusion Act, many laws and policies that we've created to expel certain groups from society. And we see it now with mass incarceration. And then violence are threats and experiences of physical or structural violence. That's pretty straightforward. I don't really need to comment on that, but I will just define structural violence as harm that is done by a group that's in power against a group that has less power. So it's just harm being done. It does not have to be physical harm. And one of the things I do want to talk about as it relates to violence and all of these forms of oppression is that when we bring in the concept of intersectionality, the idea is that there are multiple forms of opportunities for oppression or multiple venues by which one individual with differing identities can be oppressed. Then you see that these forms of oppression become even more dangerous. And so, a perfect example of that is that transgender people are significantly more likely to be victims of violence than other populations. But transgender people of color, particularly Black and Latinx transgender people, have epidemic high rates of violence and epidemic rates of murder within their population. And that has a lot to do with the idea of intersectionality as it relates to oppression. Okay, a couple of other concepts. One is this idea of essentialism. This is the belief that there are distinct, unchanging, and natural characteristics that define social groups and facilitate their categorization. This is our tendency to put people into categories and believe that they only fit into those categories and not recognize the fullness of humans and the fact that there are these characteristics that you cannot just categorize in such a way. Erasure of context is failure to consider the socio-historical context when seeking to understand the etiology of inequities. I just gave an example with Dr. Cartwright describing a lack of context, but a much more recent example of this has to do with the protest psychosis. So this is a book written by Jonathan Metzl that really describes how schizophrenia, the rise and the change of the description of schizophrenia occurred with the rise of the civil rights movement. And you all of a sudden started seeing schizophrenia being associated much more with Black people, and particularly aggressive Black men who were championing their civil rights. This idea was that there was a lack of context, a lack of understanding that fighting for civil rights was reasonable behavior, and it was considered to be, it was pathologized by many of the diagnosticians and the psychiatrists that were white people that were examining and looking at this behavior and not understanding the context behind that behavior. To this day, we have higher rates of schizophrenia being diagnosed among Black people, and particularly Black men. And some of the origins of that relate to the protest psychosis. Biological determinism is the false belief that racial groups are biologically and genetically different. I told you I would define this term. There's that definition. Biological determinism says that racial groups are different. It is so strange to me that I have to say that it is a false belief It makes perfect sense to me that there is no biological or genetic difference between races. It makes perfect sense to me, but it is still a remarkably persistent belief that many people still hold to this day. And a perfect example of that is a study that was done in 2016, actually on UVA medical students, and that found that many of these medical students had beliefs that were persistent through their medical school career, or that they developed during their medical school career. And some of those beliefs were things like Black people have thicker skin than white people. Black people have fewer nerve endings than white people. So all of those things are untrue, but these were beliefs that those medical students at the time, a significant number of them still believed. And so there is something about the way that we're teaching, the way that we're expending this information or expelling this information to people, that we still believe these false statements about the differences between races, and that there are biologic and genetic differences. Cultural determinism is the false belief that differences in racial groups are the result of cultural factors. So cultural determinism is almost like biological determinism, but instead we're now saying, oh, the difference that you're seeing in these outcomes is because these types of people, this particular racial group, chooses to eat certain foods, or chooses to have certain cultural traditions that lead to these differences. And so this gets into things like why certain populations, why Black people have maybe higher rates of high blood pressure, and it has to do with dietary choices, cultural dietary choices. Those are not true. That is not the reason why we see differences in high blood pressure rates among different races. It has to do with systemic and unavoidable and unjust policies and practices. And similarly, for Latinx populations, we often say that higher rates of diabetes have a lot to do with dietary choices like eating tortillas and things like that. And that, again, is not the driver of why we see these differences in outcomes. So cultural determinism is kind of like the cousin of biological determinism. It's saying that these differences that we see are not the result of systemic and avoidable and unjust policies and practices, when in fact that they are. Okay, so there are a couple of different types of discrimination. There is legal discrimination or illegal discrimination. Legal discrimination is what we think about when we think about Jim Crow laws. So the idea that this is state-sanctioned discrimination. Redlining is another example of examples of legal discrimination. Illegal discrimination has a lot to do with employment and the fact that within the civil rights laws, there are now protected classes. So as a result of the Civil Rights Act, certain groups, including groups that are identified by race, religion, creed, gender, and most recently LGBTQ status, that these groups cannot be discriminated against in employment settings. And so therefore, if you're in an employment setting and you're not hired because you have one of those characteristics, that is, and in fact, that is illegal. That cannot be done. But one thing that people don't really understand, it is a very narrow application. So it applies to employment, but it doesn't necessarily apply to many, many other ways that people can be discriminated against in society. And then another type of discrimination you see is overt versus covert discrimination. Overt is just as obvious as it looks. You know you're being discriminated against. Covert discrimination is kind of like what we think about when we talk about microaggressions. It's the type of discrimination where it's much more insidious and you're not sure if it's happening or not. In some ways, covert discrimination can be even more challenging because of the amount of cognitive load it takes to spend time trying to parse out whether you're being discriminated against. And that takes up a lot of time and energy to go through that process. And so it can be extremely draining in that way. And then there are multiple levels of discrimination. There's interpersonal or individual, there's institutional or organizational, and then there's structural or systemic. I think we spend a lot of time talking about interpersonal or individual discrimination. This is that one-on-one discrimination that occurs between one person and another person, or one group and another group. It is the type of racial discrimination or other types of discrimination that gets all of the press, that we hear about all of these instances in the media, but it's not actually the thing that's driving the change or the differences in outcomes or the inequities that we see. That's really much more institutional or organizational, specific organizations discriminating, specific institutions, or structural or systemic level. So all of systems within our society, or all of certain structures like the housing structure, or the criminal justice structure, all of those levels of systems. Those are the things that are really driving the differences that we see. And so finally, I'd like to define structural racism, which is a system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequity. This is a system that identifies dimensions of our history and culture that have allowed privileges associated with whiteness and disadvantages associated with color to endure and adapt over time. It is not something that a few people or institutions choose to practice. Instead, it's been a feature of the social, economic, and political systems in which we all exist. It does not require the actions or intentions of others. And most importantly, if we got rid of all of the interpersonal discrimination that exists in society today, we would still see racial and ethnic inequities due to the persistence of structural racism. So now I want to give a couple of examples of how we see social injustice playing out in mental health. So we just spent some time talking about the war on drugs, so we don't need to rehash that. But as we've talked about, we can see a lot of associations there. So residential segregation is, I think, one of the clearest examples of how we see this playing out. And residential segregation, as you know, was started with the creation of certain parts of the government identifying neighborhoods and communities, redlining those communities, and based on those red lines or those shaded areas, determining that some communities should be invested in heavily and other communities be disinvested in. And so communities of color, and particularly Black and Brown communities, were disinvested in. And so no resources, no clinics, and in extreme cases, no fire departments or any type of services were in those neighborhoods. You saw kind of certain neighborhoods flourishing and other neighborhoods really crumbling under residential segregation. Of course, this was outlawed eventually, but we still see really extensive effects of this. And one of the most, I think, disturbing things is that residential segregation has such lasting effects that it affects health in almost every aspect. So it is very difficult if you live in a community of color, if you live in a predominantly Black or Brown community, it is very difficult for you to access services, whether it be healthcare services or mental health services, because there's often not a clinic or a service location in your neighborhood. So you often have to drive extensive distance to get to the closest location. Additionally, another example of residential segregation relates to COVID, and specifically a recent study showed that within the COVID pandemic, when vaccination sites were first being put into place as vaccines were just being rolled out, what you saw is that people who lived in predominantly Black communities had to drive significantly longer distances to get to the closest vaccination site than people who lived in predominantly white communities. So we spent a lot of time talking about vaccine hesitancy as it relates to COVID, and the idea that certain populations, maybe certain cultural beliefs, make people hesitant to get vaccines, but we don't spend as much time talking about the structural level barriers, how it's much harder to get the vaccine in the first place for some populations. And that's one of the reasons why you see these differences in outcomes that aren't necessarily tied to cultural or biological reasons. Immigration policy is another example of how structural racism impacts mental health. Immigration policy has always been a way to kind of determine who gets to come into this country and who does not, and particularly which countries it's easier for you to come into this country, and which countries it's very, very difficult. But also as it relates to mental health, what you find is that for immigration laws, we do a lot of screening of populations and of patients to make sure that they don't have any serious mental health or substance use disorders. If you have schizophrenia, if you have bipolar disorder, if you have a substance use problem, you are not going to be granted immigration into this country. So what ends up happening is the screening that happens and the exclusion of certain people that have mental health or substance use problems means that, or other physical diseases that people aren't allowed to enter the country as immigrants with, means that that the people coming into this country as immigrants are often significantly healthier than the population that is here in the United States. And so in the past, we've talked about the healthy immigrant effect and why certain populations are healthier. And again, this is this thought that it's cultural differences, it's maybe choices that immigrants are making around their diets and how they interact and how they deal with stress. But but people don't spend as much time thinking about the connection between who we decide is able to come into the country based on our policies. And that is one of the drivers of the healthy immigrant effect, probably one of the more significant drivers. The Social Security Act of 1935, many of you recall that this is this act that created retirement benefits. There was this concern that older Americans were not really able to retire because they didn't have enough financial security. And so in older age, they were getting very anxious and worried about being a burden on their family. And there were concerns about how they were gonna kind of live out their golden years. But the Social Security Act came along and really addressed that by creating these retirement benefits. You work your life, you work for most of your adult life and you pay into the system. And then when you retire, you get these benefits that allows you to have financial stability in your retirement, but also allows you to pass that financial stability on to your children and your grandchildren. So really giving certain populations the ability to start a foundation for growing wealth. And so the question then is, how is this structural racism? Well, in order to pass the Social Security Act of 1935, a political deal had to be made with Southern senators to get them to come on board. And the idea was that they would pass the Social Security Act only if it excluded agricultural and domestic workers. And at that time in the South, the majority of agricultural and domestic workers were Black. And therefore, they were not able to participate in the Social Security Act, despite working their whole lives like everybody else. They did not get to pay into the system, and they were not able to retire at retirement age. They were not able to pass wealth on to their children and their grandchildren. And so you saw this huge gap start to develop between wealth. So wealth inequities really started to take off with the enacting of the Social Security Act. And then let's talk a little bit more about mental health care. So this is data from SAMHSA in 2018 that shows that 69% of Black adults with any mental illness and 67% of Latinx adults with any mental illness receive no treatment whatsoever. And then when we talk about serious mental illness, again, I mentioned that that is schizophrenia, bipolar disease, bipolar disorder, and severe depression, major depressive disorder. For those conditions that are serious mental illness, considered to be serious mental illness, 42% of Black adults receive no treatment and 44% of Latinx adults receive no treatment. And these numbers get extremely disturbing when we think about substance use disorders, because 89% of Latinx adults with substance use disorders reported receiving no treatment, and 88% of Black adults with substance use disorders reported receiving no treatment in 2018. So I want to pause and say, let's think a little bit about what is driving these extremely high rates of non-use of services. And I just want to point out that in an attempt to try to fight cultural imperialism, I did not provide the data for white people, but I will just tell you generally the data is less. So we don't necessarily need to compare the data, but we can just point out that the data, that these rates are higher for Black and Latinx adults than they are for white adults. And so when we think about this data, many times I think our thought process goes again back to thinking about this as a disparity, or thinking about the cultural deterministic or the biological deterministic causes for this difference. And so we may say that, oh, Black and Latinx people maybe have higher rates of stigma. They are less likely to seek mental health services. We also might say that perhaps they have less insight into the fact that they have a mental health or a substance use problem, and that may be one of the reasons that's driving this. Or maybe they just generally as a culture aren't really as focused on their symptoms. Maybe they're focused on other things, and so they don't really have the time or the desire to seek mental health treatment or substance use treatment. But actually, when they asked and did a survey, particularly among Black adults, cost was the most commonly cited reason that people did not seek care. And it was twice as often as minimizing symptoms, and nearly 5 times as often as stigma as reasons for why people didn't seek care. So really, when people are saying that they didn't seek care because of cost, we're again describing a structural problem in the availability of mental health services and the ability for people to be able to access mental health services. So this is a structural level problem, not an individual problem or not a cultural problem that's keeping people from getting services. It's the fact that the services are not structured in a way that people can access them effectively. And so in the time that we have left, I'd like to strategize about how we move in the right direction and where we need to go. So currently we're in the state of inequality, where there is unequal access to opportunities. And this, is how we've been for quite some time. And many people think that the goal that we are trying to reach is one of equality. And equality is when we evenly distribute tools and assistance. So this is when we say we want to make sure that we focus most on fairness. We want to make sure everybody gets the same. And as you can see here, that has been a strategy that we have employed for many years in trying to address this issue. And it doesn't really get us very far, because when we focus on fairness and making sure everybody gets the same, the people that have been oppressed and marginalized do not get what they need. So much of the focus has been, let's try and think more about equity. And that is when you give custom tools to identify and address the inequality. So it's not about making sure everybody gets the same thing. It's about making sure that everybody gets the specific intervention, the specific thing they need to be successful. And equity is a very good starting place, but it cannot be it alone. It cannot be what we're striving for just in and of itself. We also have to think about justice. So we not only have to think about making sure people get what they specifically need, but we also have to focus on how do we fix the system to make sure that we offer equal access to both tools and opportunities. So some strategies. One of them has to do with education and self-reflection. And I'll speak more about all of these. We need to promote social norms of inclusion, equity, and respect. We need to advocate for equitable public policies, and we need to speak up and take a stand. So as it relates to education and self-reflection, one of the things that's important for us to know is that we really haven't been taught, most of us have not been taught this information in schools. I did not learn any of this information in my formal education. I had a great formal education, and I did not learn any of this information. So I actually had to seek out this on my own. And much of this work, what's great about it is that there are a lot of books, there's a lot of media, there's a lot of information out there for anybody who actually wants to learn more about this. And so these are some books that I would highly recommend if you're interested in starting a journey of learning more about these topics and also creating a practice of self-reflection. And also, in addition to those books, I put these books at here because I think sometimes the books on the previous page can be a bit dense and a bit heavy. And so instead of, if you're not ready to kind of go so deep, I think that these books are an easier way to start to introduce yourself to these topics. And so these are lighter books, including How to Be Anti-Racist and White Fragility and Mediocre. They're still very good, but they're not as dense. And then I have a number of podcasts that can be very effective as well. And so these are podcasts that can help move people in this direction as well, including the 1619 Project, Seeing White, Code Switch, and Reveal. And then a documentary that I think just does an exceptional job of addressing structural racism and thinking about race is I Am Not Your Negro. So all of these are lighter ways to introduce yourself to the topic and move in this direction. But also, again, I said education and self-reflection. And so one of the things that we have to do is create a practice of self-reflection. And part of that involves becoming more skilled in using cultural humility. So cultural humility is a concept created by Melanie Turvalon and my colleague here at UC Davis, Jan Marie Garcia. And it's this idea that we have to commit to a lifelong process of self-evaluation and self-critique. So sometimes we talk about cultural competence and we say, you know, you have to get to a place where you achieve competence, but there is no end goal. There is no, like, once you've taken this much training or you've done this much work, you're finally there. And so one of the things that we learn when we think about cultural humility is this idea that we are doing this forever. We're all on this journey of a lifelong process, and that lifelong process involves constantly evaluating yourself and constantly critiquing yourself and constantly trying to do better. At each moment, can you do better in this space? And again, this is work that it's very hard to do. I find that I really struggle because I challenge myself in these spaces, and sometimes I fall very short of the expectations that I set for myself around where I need to be. And it's a matter of evaluating and critiquing and moving forward from that. We also have to desire to fix power imbalances between providers and our clients. So this relates to that point about oppression and hierarchy, and the idea that there are some things that we do in our care and in our practice with patients and with clients where there is a very specific power imbalance and there is a need for that. And particularly because I teach medical students, I'm aware that, like, in an operating room, as they're learning how to do surgery, they absolutely need to follow a very clear power structure in order to effectively learn how to be a surgeon. But much of the things that we do in mental health does not necessarily require that same level of power structure. And much of why we have certain power hierarchies and power imbalances set up within mental health is really there just to make the person in power feel empowered. And so we actually have to look at all of our structures and say, is this power imbalance here for what's the reason for this power imbalance? Is it necessary? If it's necessary, then we should keep it. If it's not necessary, though, I think that we really need to examine why it's there. Even things as small as I've worked in various different clinics in which the bathrooms are separate for clients versus providers. And it seems like a very small thing, but it's definitely creating this idea that that particular population is different and separate from this particular population, and therefore we need to make sure that that's really clear. So these are things that we should just be looking at and questioning. And again, there may be a very good reason for why there are different bathrooms. There may be some reason that that power imbalance needs to exist, or maybe there's not. And so it's really about, again, evaluating, critiquing, reflecting on, and trying to just question. And finally, the last tenet of of cultural humility is developing community partnerships to advocate within the larger organizations in which we participate. And that kind of is really about making sure we're including people and we're not necessarily kind of telling communities what to do, but we're actively working with communities to make sure that their needs are reflected in the work that we do. So then another thing that we have to do if we're learning how to educate ourselves and learning how to self-reflect is that we have to begin to become more structurally competent. Or we need to practice greater structural humility. But structural competence or humility is the trained ability to discern how a host of issues defined as symptoms, clinical problems, attitudes, or diseases, for example, depression, hypertension, obesity, smoking, medication non-compliance, trauma, and psychosis, all those different problems and symptoms, how they are influenced by upstream social determinants of health. So it's really a matter of when you're looking at and talking to the client in front of you, the client sitting directly in front of you, are you also considering with everything else that you're getting and all the information that you're required to get, are you also considering how all those many social determinants of health that we define, how they are impacting on the individual presentation of that patient? And that's really what structural competence teaches us to do. Okay, so that was education and self-reflection. I mentioned that two other things include public policies and social norms. Since they are the foundation of everything that's creating the social injustice, we have to intervene on those things. And so one of the things we need to do are promote social norms of inclusion, equity, and respect. And so I again turn to James Baldwin for this quote. He said, "We can disagree and still love each other unless your disagreement is rooted in my oppression and denial of my humanity and right to exist." And I think this is so key because many of the times it is fine to have a discussion and educate people around social norms of inclusion. But there are also times when it is threatening people's humanity and their right to exist. And I think at that time, we have to shut down those conversations and not proceed. So one of the things we need to do is enforce social norms of inclusion and equity. And that is on every level. Again, this is in your workplaces, in your families, when we hear comments being made, when we hear people saying things that are exclusionary, that are inequitable about certain populations, we all have to be the enforcers of those things. We have to be moving people towards being more inclusive and more open. And then we have to either educate or legislate to change social norms. And what we're saying here is that there is a segment of the population that really has negative social norms about populations because they just don't know any better. They've had very limited experience with those groups, and they just require some education. And so for that segment of the population, which is a significant amount, the work is not to cast that person out or to cancel them or anything like that. The work is to educate that person and help them understand where they might think differently about their thoughts and their views, and provide some education so that they can move in a different direction. But unfortunately, there is a small subset of the population that no matter how much education they have, it doesn't matter because they have hateful beliefs that are never going to change. And in those cases, and again, it's thankfully not a large group of people, but in those cases, we do have legislation. We have those laws that I described that can allow us to prevent those people from doing harm to the rest of society. And so what that looks like is in our work settings, if those people are being exclusionary or harmful to other people, it requires removing them from contact, whether it be removing them from employment or removing them from the interaction with certain populations in which they could do damage. And I do think we don't necessarily do enough of this. We don't always take somebody who's a repeat offender or somebody who is committing harm on a regular basis and prevent them from committing that harm. And that's work that we all need to try to do. We need to observe and challenge our own implicit biases. I've spoken before about how hard this can be, particularly for myself. As you get better at identifying your own implicit biases, you become more aware, and you become, you start to notice how many of implicit negative thoughts you have about other people and other populations. And so then that requires you to challenge and do this work on a regular basis. And so I would encourage everyone to give themselves some grace. You get better at this work, you start to notice how often you have bias, and then you recognize that these are things that bias is human. It is a neurobiological process, and you have to give yourself some credit, but also you have to challenge yourself to question those biases and recognize that those biases are often wrong. Those negative biases are often wrong. And finally, we have to evaluate and break down unnecessary hierarchies. And I've kind of highlighted this already, but when it comes to those social norms, we need to look at the hierarchies in our systems, and we need to determine which ones are there for a reason and which ones don't need to be there. If we're going to advocate for equitable public policies, the work involves moving beyond the walls of our clinics, our hospitals, our treatment centers, or any of our work settings, and working on the community level. And it involves advocating for policies that address social determinants of mental health. And it involves communicating with elected officials and promoting equitable representation. So what I often say to people is, because it's the laws that really drive this, that all policies are health policies, and all health policies are mental health policies. So all policies are mental health policies. And so if we're really serious about making change, we actually have to go to where policies are being made and make sure that we think about how can we make these policies as equitable as possible. And that involves forming a lot of cross-sector collaborations and community coalitions, which is work that I know you all have been doing exceptionally well. And I would also just say that there is much to be said about the importance of creating racial equity plans, racial equity committees, gender equity committees, to look at policies and to make sure that policies are not harming any particular group or particular population, and specifically to make sure that there aren't unintended consequences associated with certain policies that are being enacted. Because many times people don't set out to create a policy that discriminates against a group of people or a population, but accidentally that happens anyway. And so there is work that can be done as a group for people to create racial equity committees and gender equity committees to look at this. And so just to kind of wrap up, I will just say that political stances and policy interventions are required. And oftentimes in psychiatry, we think that we can be, I know I was trained to believe that I can be neutral, that I don't have to wade into something. And I would just say to that to remain apolitical or neutral is in fact a political stance, because it is a tacit acceptance of the status quo. And so the final thing on that list of what we need to do was really about speaking up and taking a stand. And I think that if you take anything away from this talk today, it's how important it is for all of us to use our voices to speak up when we see injustice and when we see exclusion happening. And so I fall back on this quote by Audre Lorde, who said, "When we speak, we are afraid our words will not be heard nor welcome, but when we are silent, we are still afraid, so it is better to speak." And I'm just noticing over time that it just becomes harder and harder. There is greater fear as people become more powerful in speaking up. But I do think that there is great cost to being silent. So I think this is work that we all have to do. And then to really wrap up, where we are in the state of affairs is that we've made a lot of progress in a very short amount of time. Some actually over a long period of time, but also in the short term, we've made a lot of progress. And progress is made through the passage of legislation, through court rulings, and other formal mechanisms that aim to promote racial equality. And with that progress, I think there's much to celebrate, and we can feel really good about the direction we're moving in and everything that we are accomplishing. But I also think it's very, very important that we recognize that with progress, always, inevitably, comes retrenchment. And retrenchment refers to the ways in which progress is very often challenged, neutralized, or undermined in key policy arenas. And so every time there is progress that you see being made around social injustice as it relates to mental health, you have to be ready to expect the retrenchment that will follow. In some ways, it's a guide to know that the work is being done. But it can be very demoralizing to know that that there is challenge to the progress that's being made, and you cannot get disheartened in the work. And so to kind of guide us and to end, I'd like to call on the words of former Congressperson John Lewis. And he said, "Do not get lost in a sea of despair. Be hopeful, be optimistic. Our struggle is not the struggle of a day, a week, a month, or a year. It is a struggle of a lifetime. Never, ever be afraid to make some noise and get in good trouble, necessary trouble." And with that, I'll stop there, and we have some time for some questions and some comments.
Wonderful. Thank you so much, Dr. Shim. As a reminder, everyone, you can enter into the Q&A function your questions. That is the best place to put them. If you've put them into the chat, I may not be able to find them. So please enter them into the Q&A section and I will be able to see them. All right. And there is also, for those who are concerned, there's an option to answer the question or enter the question anonymously. So if you prefer to do that as well, please take advantage of that. And I won't be saying your name here on the recording. All right, so the first question I have here, Dr. Shim, is somebody asking if you can talk a little bit about white supremacy and where this falls under the umbrella of oppression, i.e. cultural imperialism. I recently listened to a Brene Brown podcast with Dr. Yaba Blay, and her discussion on this topic comes to mind for me around what is missing in our discussions.
Yeah, I thank you for that really great question. White supremacy is kind of the fundamental driver of all of this. And so, you know, it's funny, I didn't say it as directly as I think that I probably should have. But when I talked at the early start of the talk around the founding of this country and who was elevated, I was very specifically talking about how the country was really founded under this guise of white supremacy. And so definitely as a form of oppression, and when we talk about cultural imperialism, this white supremacy thread has traveled through all of the policies that have gotten us to where we are. And I'm so glad you brought up a couple of examples of where we can see this. I'd also really strongly encourage people to read a very quick article by a person named Temi Okun, which talks about white supremacy in how it shows up in work settings. And particularly that there are certain white supremacist values that really create problems for functioning businesses, functioning communities. But yet that those values, that when we see them, we often, we place so much emphasis on them that they really get in the way of this inclusionary space that we're driving towards. And so I really would encourage people to look at that article for a little bit more context on how white supremacy is a fundamental driver of these differences that we see and these inequities that we see. One of the challenges around white supremacy is the idea that if there is this belief that one particular race is greater than the rest, there's also a belief that then there should be no help to any other racial group. And so many of the policies that we see today, like lack of access to universal health care, lack of a support system for poor populations, much of that is rooted in white supremacy. Even as it is harming other white people, it is still a value that is rooted in white supremacy.
Wonderful. Thank you so much. I am moving along here. Here's a great question, and that is, how can those in public mental health who are implementing public policy through the provision of services move towards intervening on the level of social determinants of mental health rather than risk factors, which is where we are primarily engaged now?
This is a great question. So specifically public mental health providers, I think need to kind of start sitting down and when planning. First of all, I'd like to say that I think public mental health providers have been doing this work and have been kind of ahead of the curve on this work compared to other groups and other populations. But I would say that when you're thinking about planning, about the types of interventions, the types of public health interventions that you want to implement. One of the best ways to move forward in this space is starting to think, okay, the intervention needs to be much more upstream. And so the intervention really needs to be around what are we doing to make sure that certain populations have appropriate and adequate access to employment? What are we doing to make sure that certain populations are not in like how are we addressing poverty? How are we addressing adverse childhood experiences? And that would be strategies to try and address those things rather than address risk factors would be one way to start to move further upstream. So it's really a matter of shifting your thought process. And again, I feel like this is a skill set of public mental health providers anyway, but it is a subtle shift to be thinking more upstream about what those interventions are.
Thank you for that. And not to add on to that, if this is a helpful resource for you all, I know it's double backed, but we have a presentation actually tomorrow with Dr. Joseph Williams as part of our Racial Literacy Among Behavioral Health Care Providers series on applying the advocacy strategies from the ACA, the American Counseling Association. I'm going to put the link for the registration there into the chat. So if you all would like to check that out and potentially register, it's back to back, but it might be interesting and could give you all some practical tips for the implementation and the shifting of the paradigm.
That is great. That is great. And I'd just like to say that in the book, Social Injustice and Mental Health, the advocacy chapter relies heavily on those recommendations from the American Counseling Association around advocacy. So I'm glad to see the synergy here.
Oh, wonderful. Yeah, I'm so glad I hadn't even planned it that you all would be back to back. That's just how the scheduling worked out. So I'm pleased to hear that. All right, let me see if I can find another good question to build off of some of the things we were talking about. How about this one? What are your suggestions for encouraging psychiatrists, primarily white, in engaging in this work? In the hierarchy of the CSB system, medical providers are mostly governed and supervised by other medical providers who may not believe this applies to their work.
Yes, this is a big challenge. And I would just say that I've spent a lot of time trying to convince psychiatrists that this is really important and relevant work. But I do think that psychiatrists have been socialized and medicine has been socialized in a very hierarchical system. So if you are not a psychiatrist, if you're not a physician, it is very hard for certain psychiatrists to reach certain psychiatrists who believe, again, much because of these white supremacist values and for other reasons, who believe that they may be better than other populations. So if you, certain psychiatrists, and I'm certainly not saying all, and it's actually not the majority of, but there's a significant number of them that would take certain offense if you tried to engage them in a discussion about these issues. Now, that being said, I think that those problematic psychiatrists are very easy and well-known and easy to spot. And the average psychiatrist, and I would hope that psychiatrists, particularly coming into the field now, which I think is changing significantly, are much more open to to feedback, comments, and perspectives from people that are not in their own field. and also much more less attuned to hierarchy. And so for those populations, I think it's very easy to just start a conversation and begin to work together. For the population that that you described, that it's a little bit more challenging, maybe they were older white men psychiatrists, which used to be the primary demographic of psychiatrists. I think that it's a matter of slowly trying to, that piece around education, I think is very clear. And so it's really about trying to open a discussion, trying to open a dialogue. And the dialogue is not, oh, you did something wrong, but the dialogue is, oh, you know, we're really trying to focus more on issues of racial injustice and social determinants. What are your thoughts around that? And I think slowly kind of coming to understand their perspective, and then based on that, educating where necessary, and making recommendations for partnership to bring people along. So I think the work involves bringing people along, and that's regardless of who they are, whether they be psychiatrists or anybody. It's a matter of trying to bring people along. And so I would encourage people to do their best. And then, as I mentioned, there are some populations that can't be reached, and I would also encourage people not to waste their time on those populations. Oh, you're muted, Glencora.
Sorry, there's so many windows here. I'm popping back and forth between. The next question I have here, I think is probably one that a lot of people have on their mind as kids head back to school. And that is, how can we engage this conversation in working within school settings, as many children are returning back to schools and many schools continue to minimize the impact of racial trauma on our youth. And then maybe even more contemporarily is sort of the discussions that are happening around CRT, critical race theory, which was my last addendum there.
Yes, and so I think this is a really good point, and it gets to the debate about critical race theory is, I think, just another example of retrenchment, and how when you see progress being made, and we've seen this incredible progress around trying to address racial injustice, that a common thread of retrenchment always occurs. And so the idea is maybe talking about these issues, and the idea that critical race theory is somehow problematic is very damaging. I really like to encourage people to review Beverly Daniel Tatum's book, Why Are All the Black Kids Sitting Together in the Cafeteria? Because it really talks about racial identity development. And I think that that is an area that people need to learn about before engaging in conversations with children around race. Because we are not skilled at this. I mentioned that we are socialized not to talk about this. We're socialized. We teach our children that it's impolite to identify people, to discuss race. And so we don't have a skill set by which to engage with young people around these issues. And there are people that have been doing this work and also understand that people are in various stages of development around their own racial identities, and that there's white racial identity development, and then there's other types of racial identity development as well, and that we all kind of need to have a better understanding of those things. Again, I learned a lot of identity, I learned a lot of developmental stages in my psychiatry training, and never, out of all those many different types of developmental stages, did I learn anything about racial identity development. And it's just another example of how this work is often minimized or seen to be less important, when it's such a significant part of how we all develop and grow within the world. So I would encourage people to read that book, and then begin to start to engage schools. I think there are discussion groups developing. This is work that public mental health providers could really lead dialogues on in school settings. And I think that, again, you have to be prepared for the backlash, for the retrenchment. And so, you know, I would just try to involve as many stakeholders and coalitions as possible to make sure that everybody is in agreement and on board with moving forward. But I do think it's very important and critical work to be discussed in schools and to help young people do better around thinking about race and racial identity than we have done. We've done a very poor job of this, and our young people in our society don't need to have the same challenges that we had around these issues.
Wonderful, thank you. Moving along here, we have a question, and I think I'm going to put the context around it because it came earlier, is that someone asked, and I think this must be referring to some of the stats you shared about treatment and different treatment and access in different racial ethnic groups. But it said about, I guess about the study, it said, did they ask if they did not seek care because they mistrust the healthcare system? I heard this and wondered if it's true.
Yeah, they did ask that. And I can't remember the data like off the top of my head, but definitely mistrust was one of the things that was asked. The reason that it wasn't on there is because it did not rise to the level of minimization of symptoms or stigma. So the mistrust was definitely something that some populations said they experienced, but at lower rates than stigma and minimization of symptoms, which were all at much lower rates than cost. So it is on the list and it does play a role, but again, I want to remind people that it doesn't play the role that we often think that it does. And I would also encourage people again to look back on Medical Apartheid by Harriet Washington, because she talks about how much time we spend as a society, again, because we haven't learned about race well enough. We really tend to kind of oversimplify most things. And so I'm absolutely not saying that mistrust isn't very important, because there's this extensive history of mistreatment that the medical community has displayed towards Black people. But yet still, and there's an extensive discussion in Harriet Washington's book about the Tuskegee syphilis study, which we often bring up as kind of the main reason why Black people are so mistrustful of treatment. But the truth of the matter is, the Tuskegee syphilis study, and she describes this in great detail in her book, is not really the most significant factor behind why Black people don't trust the healthcare system. And one of the things I think is a huge driver is data that I didn't share with you around the rates of discrimination that people experience when they seek healthcare. And I definitely have had multiple experiences in my life where I've experienced discrimination. And one of my normal responses to discrimination, if I experience it somewhere, is I don't return to that place. So if I go to a restaurant and I'm discriminated against, I don't eat at that restaurant again. And so many people experience discrimination in seeking healthcare services and seeking mental health care services. And so they don't return. It wouldn't necessarily be categorized under the category of mistrust, but it is, I experienced this mistreatment. And as a result of this mistreatment, I no longer I'll do whatever it takes to not access that care again, because I don't want to be mistreated again. And so people avoid care because of that mistreatment. So it's just a much more complicated picture than the ways that we lay it out. And it's a much more complicated picture than the way I laid it out for you all today, just because it's a very complex thing. But yes, mistreatment does play a role, but it is not the driving factor.
All right, next here, I have a great question that I think a lot of us are thinking about these days, especially as we are implementing Marcus Alert across our state, which is going to be the sort of mental health emergency crisis response line and system. And that is, what are some ways we can engage this conversation in communicating with law enforcement?
Yeah, and so, I mentioned as one of our solutions was forming cross-sector collaborations, and absolutely law enforcement is one of those cross-sector groups that we absolutely have to collaborate with. One of the challenges, and again, I'm so glad that the first question was about white supremacy, because much of this gets traced back to white supremacy. But one of the problems with structural racism is that So absolutely, the police have been used as a tool to perpetuate and to preserve structural racism in our society. But also, again, because of the impact, the wide-reaching impact of structural racism and the policies that we have created over time that advantage certain populations and disadvantage other populations, we have created a system in which the police are supposedly responsible for all manner of ills in our society. And so we have directly connected, again, this is all fundamentally back to social injustice. So our social norms about people who have serious mental health problems are that they are dangerous and they are violent. Those are our belief systems about this population. And as a result of that, our laws and our policies are that we have funneled the entire care system through the police, through the criminal justice system. This is why we have high rates of people with mental illness in jails and prisons, because we have turned this particular situation, which really should have nothing directly to do with the police, into a situation where the police are the primary and first and last responders for people that are having a mental health crisis. And much of the policies that we have around how we manage these mental health crises are we criminalize people with mental health problems. When I was in training, if somebody was transported to the hospital on an involuntary hold and brought in by the police, whether or not they were violent, whether or not they were at any risk of harm, they were placed in handcuffs. So, and the idea is that you didn't know what they would do, and they were unpredictable. And again, this is a norm that we have, that they're dangerous, that somebody who has a mental illness is dangerous and needs to be put in handcuffs, whether they are voluntary or involuntary, whether they're violent or not. Somebody who is depressed and only at risk for hurting themselves was put in handcuffs. So we have these belief systems and we set them up. And then we implement them. So the police are not necessarily our enemy in this process, but they are victims of a really dysfunctional system in which structural racism has allowed to prevail. And generally, I think that police are not terribly interested in caring for all people in mental health crises and managing and being the first responder for people in mental health crises. So I love the idea that you, as a state, are rolling out a crisis response. And I think that as far removed as that can be from the police, while it's still using the police in instances of violence or instances where there is risk or weapons involved, which is very rare. I think that the partnership should be around how do we handle these extremely rare issues, and how for all of the other issues do we separate this completely and not call you at all, unless there is some type of issue where there is a risk to people's safety, physical safety. There are the overwhelming majority of mental health crises have nothing to do or should have nothing to do with the police.
Wow, thank you for sharing your insight and feedback on that. And we hope to actually, within the next month, have a training specifically on this topic that I hope you all can join.
Wonderful. I'm sorry I often go off on my rants. So
no, I think your rants are well connected and yeah, definitely have some linear thinking to them. Here's a great question that someone asked, and that is, do you believe that discrimination can be eradicated even with education?
Great question. I think that we can move to a direction. I think there will always be discrimination, right? But I do think that we can move in a direction where that is the very, very small minority of people. As it stands now, discrimination is very, very common. It's occurring almost all of the time. But I do think that we can move to a place where that is, if enough people start speaking up and speaking out against discrimination, I think we can move to a place where it is very rarely happening, and it's certainly not happening among people who have power or accountability or any ability to prevent people from being harmed by it. So I don't think it will ever cease to exist, but I do think we can set up and create a society in which it does not have the impact that it has. And I think that's up to all of us to be able to create that society.
Thank you.
You're back on mute, Glencora.
I said thank you for giving us some hope. It's not often that we have that glimmer, so I like to grab onto it when we have it.
Yes.
All right, let's see what else we have here. Somebody asked, is there any data or research on the impact of same race provider on engagement in mental health services? Are normal response behaviors less likely to be pathologized?
Yeah, there's a lot of really good data on this, actually, that shows that same race and same gender providers do better. But what I think is interesting is that that data, I think, it warrants further analysis. Because one of the things I think is that we do such a poor job of teaching people of other racial backgrounds. So that same race data, we have to think about the context of it. And most of the context is that the majority of providers are white and the majority of providers are male. And that when they have done studies where they've looked at matching a Black provider with a Black patient, or matching an Asian provider with an Asian patient, or matching a Latinx provider with a Latinx patient, especially one that they can speak in Spanish together. When they've looked at this data, they've seen that the outcomes are significantly better. But one of the things that I don't think that they haven't analyzed when thinking about this is how many of the predominantly white providers have any sort of skill set or understanding about the issues that impact those populations, and how many of those white providers have discriminated against minoritized patients. And so I don't think that the issue is that you have to have a provider of the same race. I think you have to have a provider who has an inkling of an understanding of what your experience might be like. And you do not have to be of the same race or the same gender to get that, but it helps, because if you know how your experiences is you can often past that, you can often use your personal experience to help. So I don't necessarily believe that when I take care of my white patients that I'm providing worse care for them than if they were to get their care from a white provider. And I think part of that is because I very much, by growing up in this society in the United States, have a very clear understanding, even as a Black woman, as to the experiences that white people experience, because I had to understand what it's like. And I think that is the part that it doesn't always translate. That white providers have not always had to force themselves to understand what the experiences of somebody of a different race are, and that's where the problems are. It's not necessarily that it's just if we match race, we'll be okay. And the other reason why I think that this data, why I think there's more to this data, is because some of the data shows that actually what's interesting about race concordance is it doesn't always match up exactly, because what often happens, and I've seen this in my own practice, is that I have less in common with a Black person from a different socioeconomic status than I may from a white person of my same socioeconomic status. And so there are certain aspects of my experience that that don't necessarily match up just based on race. And so this is why I think our work is really about trying to be better and more culturally, have greater cultural humility, and really trying to understand the experiences of everybody, and asking people specifically, what are your experiences? And I think that's what we've been missing and what we haven't trained people to be effective at doing.
Thank you for sharing that, Dr. Shim. We have time for a few more questions here. I have one that is asking, is there a way to eradicate the stigma attached to seeking help in African American communities? Many people fail to seek help and it's often swept under the rug.
So I think it's a great question. And I'm back to, oftentimes we'll take a question like this and we'll put it on the population. We'll say, how do we change that population's mindset? How do we change Black people's ideas about seeking treatment? And that is not the work that we need to do. The work is we need to change the system and the way the system is delivering care so that Black people feel more welcome and have easier opportunities to access services. So the work is not how do we decrease stigma? The work is how do we create a mental health service that is much more inviting and much more welcoming for Black people, because as it stands now, it is not. And that is the reason why people aren't seeking treatment. That's the reason that stigma is at higher rates. It's not necessarily, and again, I'm not saying stigma doesn't exist, but I'm saying if we do our part to work on fixing the structural ways that we are completely uninviting, and I see this every day in the way that mental health services are delivered. We are completely uninviting. We do not treat people like human beings. We're not even like basically nice to people. And if we do that work, I think that much of our concerns around stigma in certain populations will improve, especially because I've done my own studies that show that rates of stigma are actually not higher in Black populations or in Latinx populations compared to white populations. So there is a lot to say that yes, there is stigma, but again, we fall into this trap of kind of seeding that in the population rather than looking at the structural causes or structural drivers.
That is a really fantastic way to reframe that question. I appreciate that. As a reminder to all those people, we still have a few more minutes here. So if you want to, you can enter your question into the Q&A function. Additionally, I've put into the chat the evaluation for the presentation, a link to if you want to join the ACA competency training tomorrow, and a way to join my listserv to hear about more trainings in the future. All right, how about this one? And this person says, I work in behavioral health and am astounded by the racism and classism I experience as staff. The issue is getting administrators and supervisors to educate themselves. We do a checkbox cultural competency. How do we move away from this?
I love this question. And this is like the fundamental thing here, right? Because yes, there is, we're in these systems that are really racist systems. And we are discriminating against our own providers, our own workers. The classism and the racism within the system is harming all of us. And oftentimes it's being perpetuated by a culture that is often led by predominantly white people who have very little understanding of these issues. And so they're not only harming patients or clients, but they're also harming workers and providers that are in these settings. So the work involves, I'm back to the same things I've been saying. I think you have to start forming coalitions. And so within your work settings, is there a group that can be brought together that can try to, that consists of lots of different members of the organization, of the work setting that you're in, that can come together to actively, a task force, if you will, that can come together to actively try to address these issues and to actively provide recommendations to your leadership around what needs to happen. And part of those recommendations will probably include an extensive education process to everybody that leadership has to participate in addition to everybody else. But I do think that these are solutions that you all have to kind of come together as a community and try to develop answers to. And I want to point out that there is a lot that can be done at the grassroots level. So when we talk about classism, the people that are at the bottom levels here, even in the face of oppression and even in the face of marginalization and powerlessness, have a lot of power. And just as an example, I'll just tell you that my medical students at my institution are the least powerful people at the institution by far. And definitely I would say that even though they have very little power individually, they've discovered that collectively they have incredible power. And so what they did as an institution is the students really drove the development of an analysis at our institution of what's called a racial justice report card, in which they analyzed all of the health system on a series of metrics to determine how well they did around issues related to racial justice. And it's an established metrics that was created by White Coats for Black Lives. And the racial justice report card only scores down to a C. You can get an A, B, or C. You can't get a D or an F on this racial justice report card because there's grade inflation. But with this undertaking that these students did, we now have a directive from our dean to really analyze all of the measures in which we scored poorly, and to come with recommendations on how to address them. And so the institution is actively moving forward around changing and improving equity, and it's all because of the students. The students which supposedly have the least amount of power. And so I mean, this may be a good place to end, but I really want to explain and make sure you all understand that even if you feel like you don't have power, if you come together and form a group and demand that leadership do something differently, it can be extremely effective in making change in this space.
Thank you so much. I think that is a fantastic note to end on. I appreciate that. Dr. Shim, again, injecting a little hope and positivity in the end. I think sometimes it is quite easy to get demoralized when you are in these systems every day, consistently navigating it. And yeah, another training that we have coming up in the future that I'm excited to share with you all is on moral injury and the impact that that has on behavioral healthcare providers. So I think that should be another excellent companion to this presentation. Just a few final reminders before we head out here into the chat. I've put all the relevant links you might need for the evaluation, the ACA competency training tomorrow. Join my listserv to read about, hear about new trainings and a certificate request. We will follow up with the recording and the slides and the certificates. That does take a few days, so please be patient. I really appreciate that. And again, one last thank you to Dr. Shim. She's headed out on vacation, which she deserves, because we know rest is a critical component of resistance. So we are happy for you. So please enjoy, and thank you very much, everyone, for joining us today.